My name is Axel Grothey. I'm the Director of GI Cancer Research at West Cancer Center and Research Institute. I'd like to update you on immunotherapy in gastroesophageal cancer because a lot has happened right after ESMO 2020, when we've seen a change really in the landscape of the use of immunotherapy in upper GI malignancies. So as of February 2021, this is the landscape of FDA approval of IO agents in GI cancers, and we'll focus on esophageal and gastroesophageal cancers. And all these data that I present today have already made inroads into NCCN guidelines. So this is affecting practice of care right now. So when we look at the development of immune checkpoint inhibitors in gastroesophageal cancers, there were successes and failures over the last 5 years. It started out with actually positive data from ATTRACTION-2 in Asia phase 3 trial that led to the approval of Nivolumab in an unselected patient population in a later line setting in a trial compared to placebo. Then we had a non-randomized phase 2 study in the United States and Western world, that gave us pembrolizumab. But then there were some failures as soon as the immunotherapy was compared to active chemotherapy in randomized comparisons. And there were some lessons learned that, most patients actually do not benefit from anti-PD-1, PD-L1 therapy, that PD-L1 expression levels were somewhat important to select patients for the use of the IO agents. But, the data that came at ESMO really refined our understanding about these features and really gave us new standards of care. And I want to highlight one study in particular, the checkmate 649 study in international collaboration, Western world, Asia, adding Nivolumab to kind of current standard of care chemotherapy, an oxaliplatin-based treatment approach in first-line HER2-negative G-junction gastric and esophageal adenocarcinoma. So one of our standards of care in the HER2-negative patients using FOLFOX or CAPOX, in this study in a large randomization looked at the addition of Nivolumab to the standard chemotherapy. And this is the arms that were actually presented at ESMO with dual primary endpoints, overall survival and progression-free survival, primarily focusing on patients with cancers expressing PD-L1 in a combined positive score of 5 and higher. And that is important to know. So that's a select patient population. Most of these patients were non-Asian. Most of these patients were had gastric cancers, and only a few patients had MSI-high tumors, which is important because we know these patients do benefit from immunotherapy anyway. The primary endpoint, this PD-L1 CPS score 5 and higher, was nicely met with a hazard ratio of 0.71, a 3.3 months difference in median overall survival. So clearly a 29% reduction in the risk of dying. This is, I think, one of the things that establishes a new standard of care. So when we then looked at, tumors that had lower CPS expression, lower PDL expression scores, you can see here on this slide, 1 and higher are all patients, including CPS negative tumors. You see the hazard ratio actually attenuates from 0.71 to 0.77 and 0.8. So there's some loss of efficacy. We have not yet seen a breakout of these patients with CPS 1 to 5, which I think is critical to really see how the FDA will eventually look at these data to see which patients are eligible for the addition of Nivolumab. Progression-free survival, the same idea, CPS score-based improvement in primary endpoint, the co-primary endpoint of progression-free survival. And we see that in the overall survival forest plot subgroup analysis, really there's not a single patient population that did not benefit from the use of Nivolumab added to chemotherapy. Responses were higher, significantly higher by 50%. And we know it's a common feature of immunotherapy. When we see a response, responses are durable. So this is really some of the intriguing factors of the addition of Nivolumab to standard of care oxaliplatin-based chemotherapy in first line. And the summary slide that the authors presented, I think reflects, in my opinion, it presents a new potential standard first line treatment for a patient with a CPS 5 and higher PD-L1 expression score. Now, the interesting thing was there was an Asian study that had kind of different results. ATTRACTION-4, Nivolumab added to standard chemotherapy. This is a study conducted in Japan, Korea, and Taiwan. And we know that the Asian gastric cancer tumors have different biology. They have longer survival. It's more difficult to show overall survival benefit because a lot of second, third line treatment crossover, which I'll show you in a minute. And this was a very similar study compared to the checkmate study I just presented. Nivolumab added to SOX, S1 oxaliplatin, so a different fluoropyrimidine, or CAPOX, primary endpoint PFS and overall survival. Progression-free survival was improved with a hazard ratio of 0.68. This was not selected for any PD-L1 CPS score, so keep that in mind. Overall survival, however, no difference at all, but you can see long overall survival over 17 months compared to the 40 months we've seen in the checkmate study. So again, it's more difficult to show overall survival improvement in the Asian world. Similar to checkmate, however, higher response rate, durability of response is higher, is longer. So there are some similarities. The only difference is the overall survival that was not met in attraction 4 in the Asian world. So you can see here the similarities and distinctions. I think the main point here is that the checkmate study selected patients for a CPS score of 5 and higher, so some PD-L1 refinement, but both trials actually met primary endpoints, even though the attraction study only met PFS. And I already mentioned, that the overall survival results of the attraction 4 are longer, numerically longer than checkmate 649. And, we've seen, a lot more second and third line treatments in attraction 4 and more crossover to immunotherapy, which of course affects the overall survival results. It's more difficult in Asia to really show a difference in first line treatment, even if you have an active treatment option available like here. So take home message from my point of view, patient with PD-L1 CPS 5 and higher gastric cancer and gastroesophageal cancer, adenocarcinoma treated with oxaliplatin fluoropyrimidine, like CAPOX, like FOLFOX, plus nivolumab, have a median overall survival now of more than 14 months, significantly improved. And this is a milestone for non-Asian patients. And I believe a new standard of care already reflected in the NCCN guidelines. Now, switching to esophageal cancer. So first we talked about gastroesophageal cancer, adenocarcinoma, and gastric cancer. Now clearly focusing in esophageal cancer, the Keynote 590 study, so a pembrolizumab study, looked at first-line chemotherapy with pembrolizumab, chemotherapy standard 5-FU cisplatin in an Asian and non-Asian region conducted trial. Again, dual primary endpoints, overall survival and progression-free survival. And these were patients that had either adenocarcinomas or squamous cell cancers in the esophagus or CVAD1, so upper GE junction cancers. 50-50 split between Asians and non-Asians, which I mentioned is important, more squamous cell cancers. And a lot of these patients, this is the primary endpoint, like the primary endpoint study group, had a CPS score and PD-L1 expression level of 10 and higher, was a 50-50 split. So breaking it down by squamous cell cancers and adenocarcinomas and by CPS score, first, the esophageal squamous cell cancers with the high CPS score, you can see there's clearly a difference in overall survival, strong hazard ratio of 0.57 for the use of pembrolizumab added to cisplatin and 5-FU. Now, when you look at the overall patient population, squamous cell cancers, independent of CPS score, the hazard ratio gets worse, attenuates a little bit, but it's still positive. Again, we have not seen a breakout between, let's say, patients just less than 10 CPS score. So these are all lumped together, including low and high CPS scores here. Now, including adenocarcinomas, which is important because that's the patient population that we see in the Western world more, again, broken down by CPS score, high, and all patients can see, again, statistically significant, and I believe clinically meaningful results for CPS 10 and higher, all patients, again, with a caveat that these patients, of course, include the high CPS scores, and we need to see a breakout eventually of the low CPS scores to really make a call here. You can already see on this slide here that the CPS less than 10 patient tumors did not perform as well with a hazard ratio of 0.86 in the left lower bottom part of the slide. Histology, however, did not seem to make a difference whether it's squamous cell cancer, adenocarcinoma. There seems to be a trend toward better outcome in Asian patients compared to non-Asian patients. But overall, at least for the CPS 10 and higher, I think these data are pretty convincing. And we see, again, higher response rate, durability of response is longer with the IO combination compared to the chemotherapy alone. So in summary and conclusion here, yes, I believe that this leads toward a new standard of care for the CPS, high PD-L1 expressors, adenocarcinomas, and squamous cell cancers. And I think this is something we need to consider in our clinical practice. And I think one of the most intriguing data actually came from the last study that I like to talk about, Checkmate 577 study, which is an adjuvant study in patients who underwent trimodality therapy for esophageal or gastroesophageal junction cancers. So this is the situation that we now consider standard of care for the esophageal and gastroesophageal junction cancer, where we use radiation therapy, use radiochemotherapy, followed by surgery. And there are patients who still, after this neoadjuvant treatment approach, have pathologic residual disease. The question is always, do we need to give additional treatment? There have been attempts to add additional chemotherapy post-resection, but patients after an Ivor-Lewis resection, esophagectomy, are not necessarily in good performance status so that they would tolerate chemotherapy. So this is where Nivolumab now comes into play here. This is a randomized global phase 3 study looking at adjuvant Nivolumab compared to placebo. Nivolumab administered of up to a year, 2-to-1 randomization in this setting. And, with adenocarcinomas and squamous cell cancers were included. This is really a patient population relevant for the United States. Most of these patients were white. Most of these patients had adenocarcinoma. So this is really our patient population. And the disease-free survival in the adjuvant setting here doubled from 11 months to 22 months, strong hazard ratio 0.69. So it's a 31% reduction in the risk of recurrence. We don't have survival data yet. This is disease-free survival data, but clearly highly statistically significant and had major inroads already into the NCCN guidelines. And the data were positive for adenocarcinoma and squamous cell cancers. And now for tumor cell PD-L1 expression level, it really didn't matter whether tumor cells had high or low PD-L1 expression levels. This is not the CPS score that we talked about before, but tumor PD-L1 expression levels. So this is something different that we need to keep in mind. So summary, this is the first adjuvant treatment, really, the first adjuvant treatment after trimodality therapy that shows a statistically significant, and I agree, clinically meaningful improvement in disease-free survival. And again, the NCCN guidelines have already embraced these data. So take-home message from the esophageal cancer studies: an advanced metastatic esophageal cancer with high CPS score, potentially also lower. I like to see the breakout a little bit more in the Kaplan-Meier analysis. Pembrolizumab plus platinum fluoropyrimidine is now standard of care for squamous cell cancers and adenocarcinomas. And if you have a patient after trimodality therapy, esophageal cancer after resection, and you see residual cancer in the specimen, adjuvant Nivolumab up to a year can now be considered standard of care with a numeric doubling of disease-free survival over time. So we have really seen a change in the landscape of IO therapy, immuno-oncology in upper GI cancers, really based on one conference, ESMO last year, which unfortunately was virtual. But again, this has dramatically impacted our standard of care and has led to improvements in outcome for our patients.